Welcome back to this session on artificial intelligence for the public's health. I'm just going to set the scene before inviting the speakers to give their presentations and let you know about the logistics of this session. My name is Meng Ko. I'm the Centre Director for Public Health England in the East Midlands. In 1637, the French philosopher René Descartes acknowledged that machines might be able to replicate human actions very well, but did challenge us by questioning whether machines can give meaningful responses to whatever is said in its presence. Centuries later, in 1950, Alan Turing, famous for cracking the Enigma code, predicted that computers would have the capability of replicating human response. And as he predicted, more than half a century later, artificial intelligence is a reality, with wide-ranging applications, including Deep Blue, which was a computer that defeated Garry Kasparov, the then world chess champion. We also have AlphaGo, which then went on to defeat the world champion in the game Go, which is a game more mathematically complex than chess. And then even more recently, AlphaGo Zero, which was able to teach itself in 3 days and went on to defeat its prototype. Such as the advances in artificial intelligence. And of course, we've got voice-to-text applications such as Siri, Cortana, and Alexa. And we have self-driving cars. So artificial intelligence is the theory and development of computer systems able to perform tasks normally requiring human intelligence, such as visual perception, speech recognition, decision-making, and translation between languages. AI continues to progress, and applications in public health are developing at pace. For example, there are rich opportunities of whole genome sequencing of pathogens to improve the control of transmission of communicable diseases, and this is being covered elsewhere in the conference. Earlier today, we also heard about the role of digital and AI technology in public health marketing. However, in this session, we're focusing on 2 applications of AI in decision-making for public health. Firstly, in the context of human behavior change, and secondly, in clinical genomics. We also recognize that artificial intelligence is not without its controversies, and it would be an oversight to discuss AI in public health without a debate on ethics. So we have 3 presentations, and how we're going to run this is, after each of these presentations, there will be time for questions specifically on that topic. We also want this session to be interactive. So following the 3 presentations, I'm going to invite Brian to lead a discussion around the ethical aspects of AI in public health, and then there'll be a wider Q&A session for the whole panel. So please do start thinking about the questions for the panel discussion. So first up, it's my pleasure to invite Professor Susan Meeke, who is Professor of Health Psychology and Director of the Centre for Behaviour Change at University College London. Susan will introduce us to the Human Behaviour Change Project and how artificial intelligence will facilitate the work. Susan.
Thank you, and thank you for organising this session, which I think will be very interesting. In my 12 minutes, I'm only going to be able to give you the headlines of this extremely ambitious 5-year project, but I hope I will give you a sense of what it is, and I will point to a couple of resources where you can find out more information. So the background to this is that I think, as probably most of us know, public health interventions to change behaviour have got a mixed impact. So we have a very rich source of theories and methods for intervention design and evaluation. There's considerable investment in interventions aimed at both individuals, communities, and populations, and an estimate of hundreds of evaluations of behaviour change interventions being published every day. So more than we can possibly keep up with. And any of us who've looked at the literature will be aware that most of these have modest and variable effects. So the starting point is, how can we improve this situation? So we need to be able to answer what I'm calling the big question in behaviour change, which is, when it comes to behaviour change interventions, what works compared with what, for what behaviours, how well, for how long, with whom and in what setting, and why? Now, any practitioner or any policymaker or any researcher in this area isn't asking that entire question. They're asking variants of it and a part of that question. But that's the ultimate question we want to address. And having spent 8 years on NICE's Public Health Interventions Advisory Committee, looking at human beings, systematically reviewing literature to address questions that are put to us by government ministers and other policymakers, and coming up with the answer 2 or 3 years later with only a partial part of the evidence and not being able to answer even quite simple questions, let alone more complex questions such as this, I thought we need to do better. So the challenges are several. First of all, there's the research conduct. So synthesizing evidence to really be able to answer this question is hampered by the fact that we have a wide diversity of research methods and topics, which is good, but it does make synthesis more difficult. And we also have an incompleteness in reporting. We've got resource limitations. We simply have insufficient human resources given the increasing volume of research. And the research findings are usually equivocal or contradictory or completely absent relative to the variety of behaviours, interventions and contexts that we're interested in. And also, as we've heard in other sessions at this conference, there's really quite a complexity of interactions between intervention components, between them themselves, but also between them and their context and between them and behaviours. So what are the solutions? On the right-hand side, the first, in terms of the diversity and the messiness of our research literature, is to develop an ontology of behaviour change interventions. I will go on and explain what I mean by that. In terms of resource limitations, it's the use of automated literature searching and automated study feature extraction. So we're not dependent on human beings to do this. And in terms of research findings and trying to synthesize this, being able to use machine learning and reasoning algorithms, both for evidence synthesis, but also for interpretation. And one of the things this will allow us to do is be able to answer questions about under-researched areas. Certainly my experience on the NICE Public Health Interventions Advisory Committee made me painfully aware that the majority of evidence is produced in North America, and where the burdens of health and other issues in the world are in other continents outside of North America. So we need to be able to make inferences from what we know to what we don't. The Human Behaviour Change Project is a 5-year collaborative award from the Wellcome Trust. Those of you who are interested, there's the website and Twitter if you want to follow it. The collaboration is between behavioural scientists, so that's a mixture of psychology and sociology. Computer science, which is a combination of academic and also IBM research laboratories based in Dublin. And system architecture, which is the team that are making the interface between the knowledge system that we're creating and human beings. So a very important part of the project. So in a slide, what we're trying to do is address this problem of very messy evidence that's growing faster than we can cope with. What we want to do is turn this into well-organized, useful scientific insights. So up-to-date estimates of the effectiveness of behavior change interventions, and I will stress up-to-date, not 5 or 10 years old. Unpacking reasons for heterogeneity in intervention effectiveness. One needs huge amounts of data before one can really look at modifying variables and be able to look at this. And then what I, as a behavioural scientist, am particularly excited about is generating new testable hypotheses about behaviour change that we've not managed to do because we haven't managed to look at the entire evidence in the way I've described. So how do we get to the problem, to the solution? Artificial intelligence and machine learning and natural language processing, which means that the knowledge system we build will be able to recognize text and also tables and extract information into the ontological structure that I will show you the top level of in a minute. For this to happen, we need to train the system. So we've got a fleet of behavioral scientists who are developing the ontology, which provides the organizing structure to guide the knowledge system. So it's completely collaborative. Both parts are totally dependent on each other. Ontologies are like a Rosetta Stone. They connect the humans and the computer. It allows us to connect facts into knowledge in a manner that's meaningful for humans and analyzable by computers. Now, here's the very upper level of the behavior change intervention ontology. If you look at the bottom left-hand side of the, maybe I've got a laser here, of the intervention. We've got there the content of the intervention, the behavior change techniques, and also the delivery, who's delivering, mode of delivery, etc. Then we have the exposure. So the extent to which the intervention changes the outcome behavior depends on the exposure, which is the reach, but also the engagement once they've reached the target population. And these moderate the relationship between the intervention, the way in which the process of change, the way in which they operate, and the outcome behavior. And finally, we have the context, the population and setting. Again, these are modifying variables. So in order to understand the outcome behavior and the effect of the intervention, one needs to combine the knowledge in all these areas together. Now, sitting under every one of those entities is an absolutely enormous taxonomy or ontology of the entities underpinning it. So probably the simplest is the intervention content, which is work that myself and colleagues did a while ago, which identified 93 behavior change techniques in 16 different groupings. But when we go on to mode of delivery, the mechanisms of action, the behaviors in themselves, think about trying to develop categories, entities, and relationships between entities that can summarize all the knowledge, the relevant knowledge in the literature. Now, I should say that we're starting with a use case of smoking cessation. That's what we're working on at the moment. We have said we'll cover excessive alcohol consumption, physical activity, and also dietary consumption. But it's very much a proof of principle. But if we can achieve this in these areas, these principles will be applicable across the board to potentially any behaviors. And I should say that everything we're doing is open access. As soon as we have anything that's useful and usable, it will be up on the Open Science Framework and be open to everybody to share. So it's a very collaborative project. Okay, so this is a slide produced by our computer scientist colleagues to show the types of analyses that they are training the knowledge system to do using reasoning and inference algorithms. So in the first column, there's the simple searching. What has happened? So they're finding the reports that are aligned with a given user scenario, i.e., think of the question that you might want to ask of this system. And also to find, well, what is underrepresented? Where are the big gaps here? Then secondly, it will be able to predict, okay, what could happen? What's the sort of outcome range for a given experiment or scenario? And so it can predict the effectiveness, so it can regress and classify. Then there's recommend. Now, this is their language. This is computer science language. One of the interesting things about collaborative working with very different disciplines is getting used to each other's ways of thinking and also ways of talking. I think we would call it suggest options. So what should or could be done. So it may recommend an intervention to a policymaker based on their particular scenario. Now, the likelihood is that a range of possible options will be presented because it will depend rather which of the different kinds of dimensions are most valued by whoever the user is. And finally, and very importantly, this is not going to be a black box. It's going to be able to explain what has worked and why it's worked. So describing the basis of the recommendations so that the user can accept or reject these suggestions. And it will also provide degrees of certainty about the recommendations they're making. So to give two examples of the kind of questions that two users might have. So on the left-hand side here, you've got the users. Now, it's going to be a two-way interaction. So the users will be able to feed back into the knowledge system as well as being able to take from it. On the right-hand side, we've got the knowledge system working away, scanning all the world literature up to date, that's the vision, to detect patterns and make inferences. Now, a behavioral scientist such as myself, who's very interested in not just do things have an effect, but how they have an effect, I might ask, what mechanisms of action are likely to account for the effect of a certain intervention on a certain behavior? However, a public health policymaker is more likely to ask a question of the nature of what do I need to do to bring about this change in this population? So you can see both of these are very simplified parts of the big question I introduced before. So one can go from anything, which is really very simple, up to a really complex question. Now, I'm not expecting you to have followed very much of that. I'm not even expecting you to have believed very much of that. But if you're interested in following up, this is the study protocol that's been published in Implementation Science, which is an open access journals. And the details of the methodology are in the supplementary files at the end. So if you look it up, do go to them. And the website is where you'll get the most up-to-date information about what you're doing, where you can sign up to in terms of getting newsletters, or if you want to be a stakeholder and participate in any of our activities over the next 3 or 4 years, you can also do that. So the website is www.humanbehaviorchange.org. Okay, and that's it, and that's the website of the Centre for Behaviour Change that I run, that is the two main missions are bringing very different disciplines together, or all disciplines together, to address the issue of behaviour change. As we heard earlier today, no one discipline has got the answers. And also its other mission is to translate academic expertise to the world outside, to all the people who can actually make good use of the knowledge to address the many problems that as a society we face. Thank you.
Thank you very much. So we'll have time for 2 or 3 questions or comments, and what we'd like to do is group them together. So anyone with any questions or comments, the mic will find you. Down here.
If you group them together, I'm very unlikely to remember all 3 of them.
Okay, let's do them one at a time then.
I should have brought pen and paper up.
Thank you. Tim Chadbourne, PhD, Behavioural Insights and Evaluation. I wonder if I just focus in on the context bit, because that seems to be maybe the most diverse. And particularly, we've heard quite a lot around systems in this conference, and so the sort of different levels that you might have to think about and how that could be reflected in a model.
Yeah, so we're defining at the moment settings by population and by setting. With ontologies, there's a whole world of ontologies out there which we're discovering. But good practice is to go with the ontologies that already exist and use what you can from them and then build onto them. And then you register them with something called OBO Foundry. And it means that it's open to other people to comment, to extend, etc. So the settings is an absolutely huge ontology. But what ontologies are entities and then how they relate to each other with relationships between them. So they are, in essence, systems, because that's what systems are, but we've got these discrete things. So when you come to things like, say, culture, or very nebulous kind of wording, then one has to think about, right, how am I going to define culture in terms of, you know, is it aspects of the population? Is it aspects of the setting? Is it actually aspects of the intervention? So it does force you to think extremely precisely and clearly.
Thank you, that's great. Any other questions? Nikki, just down here. We'll make this the final question, I think. Thank you.
Nikki Connor, PhD, HIV and STIs. I've been to a couple of sessions. One we went to on well-being, another on young people's mental health. Lots of people are trying to build evidence bases. And is this going to be the way forward? Is it all going to be by algorithms now? Is this the future of our public health of evidence?
Well,
it's very exciting.
It's so much more efficient. I mean, probably a lot of us in the room have tried to do systematic reviewing. It's a nightmare. And one only gets a tiny part of what's available. I mean, one of the things I should say, at the moment, we're only looking at English language, but translation, you know, can be done quite efficiently through AI. And think about the amount of evidence there is in parts of the world where it's not written in English. So if what we want to do is really get a comprehensive view of what's going on, and being able to have enough evidence that one can look at it in fine-grained ways, like why does it vary between different settings or different populations, or does it vary, then the only way is going to be through computers. No, and the Wellcome Trust, when they phoned up and said, yeah, you've got your £3.7 million, they said, well, it's very left field, but it was unanimous. And they said, how can you convince us that you can do this? And I said, I absolutely can't. You know, I absolutely can't. But I said, what I can say is that the current system is not fit for purpose, to be, you know, given the acceleration of evidence that's being presented and the limitations of our own brains and time. Secondly, however far we get down the road towards doing what we said we'll do, we'll be a lot further on than where we are now. This approach has to be done. And thirdly, you know, what other team of behavioural scientists and computer scientists with a track record of working together, etc., can do this? Anyway, they seem to buy it.
Good. Thank you. I think we'll call it an end. If you could just keep your question till the end, that would be great. Thank you, Susan. So Susan has asked the big question about what works compared with what, for what behaviours, how well, for how long, with whom, in what setting and why. And, you know, the work on smoking cessation will be very welcome by practitioners in the field. And we really look forward to welcoming you back to report on your findings at a later date. So we now turn our attention to the application of genomics and explore the application of AI in the clinic. And my real pleasure to introduce Dr. Professor Julian Barwell, who is a consultant in clinical genetics at University Hospitals of Leicester and Honorary Professor of Cancer Studies at the university. Julian runs a specialist clinic on inherited disorders, including familial cancer susceptibility and inherited dermatological disorders, and will give a clinical perspective on genomics in his practice. Thank you.
Thank you very much. So I saw a patient last week, a young lady from Asia who was diagnosed with an ovarian tumour at the age of 30. Grandmother had been affected with breast cancer, but not much else in the family. She came to see me. There was some concern as exactly what the histology was on the tumour, but she wanted to know why had this happened, what did it mean for her and her treatment, and what did it mean for the wider family. This is what cancer genomics and genomic medicine is all about. It's about when mummy and daddy love each other very much and close the door, and the genes we inherit, but also the changes which occur in our body over time. In our DNA, that's the somatic changes, but also the circulating DNA, and adding in complex layers of data in time in a systems biology fashion to be able to create mathematical algorithms which then provide you the opportunity to make predictions for health. Now, for that to work, you need it to be, the data entry has to be robust, and then we have to add trust. There has to be data entry, and there needs to be a sentry. I won't keep going on like that, I promise. But it's work in progress. I would say at this stage, we're in the identification and the interpretation phase. But I think it's a while until we can use these types of systems to make better predictions for health. And I'll be talking more about that through my talk. So, personalized medicine is not new. I ask people what's the most dangerous inherited disease that we deal with in clinical genetics. And people say, ooh, thalassemia or things like that. And I say, well, what about rhesus disease of the newborn? That's a genetic condition, but we just don't think of it in the terms of clinical genetics anymore. It's been mainstreamed. We deal with it. We don't think about it. And by and large, it works very well. Somatic testing, estrogen receptor status or Herceptin testing for HER2, hypercholesteremia. These are all genetic tests, but we don't consent for them. We don't send people, by and large, to clinical genetics for them. And we want to get to a situation where we treat disease for what it is, not what it looks like, because a microscope is over 500-year-old technology. And we screen people based on risk rather than purely on age. And this is the type of thing we'll be able to use genomic medicine for if we understand what it means and if we develop enough data. The question is, how much more can clinical genetics and genomics add than we already know? For instance, for Father Ted, the actor, Dermot Morgan, had grey hair at an early age, which interests me. And he's very sad he died from a heart attack. Now, we know grey hair is a risk factor for heart disease at a young age. That's a couple of people do it in breath of air. Some of us, I'll rephrase that, some of us knew that it can be a risk factor for heart disease. Come and see me afterwards, some of you. But the reality is that we hope to be able to add increasing complex data to be able to make better predictions, for instance, for type 2 diabetes. But is it really better now than whether or not you exercise and the food that you eat and your body mass index? And the reality is that often for the complex polygenic conditions, we're struggling. Clinical genetics is very good for those who've got Mendelian conditions. These are single gene disorders. Now, these are not as rare as you may think. 1 in 17 people have one of these conditions. And obviously, up to half of us will develop cancer, which is a genetic condition, not inherited by and large, but it is genetic. And a lot of those genetic changes can be identified and be used for treatments. But if we're looking at trying to predict who's going to develop these rare disease, 1 in 17, or use genetic factors when it comes to making screening decisions or treating tumours for the wider population, we need to understand this data better. Unfortunately, for things like Alzheimer's disease that Barbara Windsor has been recently diagnosed with, there are some genetic factors which are in genes, but there are also these subtle variations throughout our genome which seem to confer risk. We don't always know why they confer risk, but these subtle variants, which are throughout the genome called single nucleotide polymorphisms or SNPs, we're going to be hearing a lot more about this, particularly when it comes to things like breast screening, because actually these can further clarify risk and be added into other factors such as estrogen exposure, body mass index, and alcohol, whether you've had children or not, to actually further define screening decisions in the longer term. How people respond to having their screening taken away is another matter entirely, and I defer to my other speakers for that. Now, the ladies in the audience are far too young to remember Ted Rogers and Dusty Bin. But we had to think about the type of patients that were being referred to us, and here are some of the reasons. To try and get a feel for for what are the common patterns, because first thing that's got to happen for someone to understand that there is something potentially inherited or genetic going on. And what we found that worked, because there are so many different criteria and guidelines, as you know, is to think about Ted Rogers, and I'll try not to abuse you, the 3-2-1 approach. So if you have 3 relatives affected across 2 generations with 1 diagnosed under 50 of any condition, but also particular tumour groups like breast and ovarian cancer, for instance, that can give us a clue that there's an inherited link. So it's a universal triage. So identification is key. How many women do I see present to me with metastatic breast cancer and the GP said, you don't need to worry, your family history is on your father's side? How many people have to die because they don't understand basic inheritance? Forget artificial intelligence. I see people where there's 6, 7, 8 people affected with breast cancer before somebody realizes there's something going on, because people either don't take a history or they don't do anything about it. So ownership is key, and it's just as important as artificial intelligence. Get those things right. So we can do more computer modeling in terms of trying to work out the likelihood of finding a gene or the likelihood of someone developing a tumor. Now, Angelina Jolie had preventative surgery because she had inherited an alteration in the BRCA1 gene, tripled referrals. We wrote a paper called The Angelina Jolie Effect that you may have heard of. I'd always hoped that she changed my life. It wasn't quite what I had in mind, but obviously attitudes are very important to ownership and empowerment when it comes to genetic data. Well, how are we using this, and how are we trying to address this? We've developed a simple 90-second triage system to try and help people work out if they're potentially at an increased risk of cancer. It's called Cancer PDX. We give the patients the opportunity, the control, to draw up their family history at home. That then goes up to the hospital, and it produces red flags, so we can see, the patient can't see, but we can see if there are potential syndromic links between that. And we've got a series of standardized letters. So this will help with identification. There's a huge amount of work going on through the 100,000 Genome Project and other projects looking at the interpretation of genomic data. Coming at the end of this month, but certainly at the end of this year, will be the new genomic medicine service. And this will be whole genome sequencing, looking at 6 billion base pairs for individuals to look for inherited diseases or cancer. You may not be able to read all of those at the back, but for instance, a child with a suspected inherited condition, such as developmental delay, will be able to access these types of tests. This is a huge step forward, and at least half of these individuals will get a molecular diagnosis, which will be important to share with other families so they can find out similar stories, but also to work out what other diseases they might be at risk of, reduce the number of times they have to keep going back and forth to try and make a diagnosis, and to give decisions for reproductive health as well. Now, the problem with some of this, particularly in the cancer arena, is not the price of the diagnostic, it's actually the price when it comes to the therapeutic. And when we went to the Finnish embassy, the health minister went straight to this point. Who's going to pay for these drugs that we identified that these cancer patients might benefit from? So we need to get linked commissioning. We need to link together the patient pathway. We work in histology. We work in molecular diagnostics. We work in clinical genetics, surgery, chemotherapy, public health. It's not going to work. So we need to work more effectively as a team. To give you an idea of how this is progressing, there's 2 different scales here. So what we have is a number of people who have taken part in blue, percentage yield. So this is additional yield of molecular diagnosis for those that have failed to make a diagnosis through standard routes. So by looking at whole genome sequencing, which takes a long time, and we all have at least 400 variants, which might be significant. So although we're going to get more diagnoses, understanding the complexity of the data is going to be a problem. And it's only when we actually look at long-term survival data and factor that in, and this will all have to be entered, that we'll be able to move to artificial intelligence. So I think we are still some way off being able to use this. We can certainly use computer algorithms to help predict risk, but we need much more outcome data to be able to use this yet in clinical genetics. With regards to data storage, it's the question we get asked most when it comes to genomic data. The question is, who am I? And at the moment, we think of ourselves potentially as our photo, picture of ourselves, maybe our fingerprints and the way we think. But in the future, we may consider ourselves or be considered to be a biometric algorithm, an equation based on all sorts of genomic data. And people worry about their own identity and their confidentiality. In America, in small companies already, there are concerns about health insurance when it comes to genomic data results. Once we get better at predicting what will happen to patients, who's to say the insurance companies are not going to start to wake up here? So they'll create a huge number of concerns about data security and data use. It's exciting times. We're only really at the end of the beginning, and thank you very much for the opportunity to speak to you today. Happy to take any questions.
Again, so thank you for that. Any questions or comments for Julian? You've stunned them to silence. Final opportunity. Don't be shy. Okay, we can park any other questions to the panel discussion, so thank you very much. So we've had two examples of advances in technology that will rely on machines to help us make decisions. However, there are ethical considerations in this debate, and to start the conversation, it's my pleasure to invite our next speaker, Brian Vernon, Senior Lecturer in Healthcare Ethics in Newcastle University, and Brian's also the Honorary Treasurer of the Institute of Medical Ethics and the first Chair of the Newcastle Mental Health Trust. He's also an Anglican priest based in an inclusive church and has ditched his dog collar to be here to pose the question to us, can artificial intelligence outwit ethical intelligence? Thank you.
Thank you. Thanks for the invitation. When I was treated for pneumonia last year, I thanked the team. This is the first opportunity I have had to thank a team of people who are protecting and improving my health as part of the nation's health. And much of the time, I just take that for granted. So, thank you. Now, I have 10 minutes to answer this question. Ethical analysis sometimes treats anything novel as dangerous. In the conference abstract, you can read what Sidney Smith had to say. These examples from E.S. Turner show our ability to adapt to social change. In the process, we espouse certain values and we discard others. The lives of child chimney sweeps and sailors have acquired more value. Married women moved from being property to owning it. Daniel Wagner is more pessimistic in his assessment. He does raise important concerns. Shared values are always endangered by the efforts of individuals and collectives to achieve supremacy. Humans also have a great talent for outsourcing blame. Without being naive or complacent, there is, though, a good case for saying that vigor, transparency, and honesty have never been totally overwhelmed by inertia, opacity, and duplicity. We have the tools to retain and develop our shared values and some experience in using them. The Future of Life Institute has created 23 principles designed for the safe development of artificial intelligence. Over 2,000 people have signed up to them, and I shall highlight 5 of the principles. Widely shared ethical ideals. How widely shared does the ethical idea of a master race have to be before it is acceptable? Principles have a number of drawbacks. They require interpretation, and once you have more than one principle, you have to judge between them when they conflict. The gamekeepers who laid man-traps did so in accordance with human values. They happen to be values that I don't share. But what are human values? The next principle tries to explain. Some people believe that it is more dignified, though, to accept death when it comes, even if it is protracted and unpleasant, while others think that dying at a time and place of their choice is more dignified. Rights are frequently contested and often conflict. Isaiah Berlin famously pointed out that freedom for the wolves often meant death for the sheep. Does cultural diversity privilege a gay couple who order a wedding cake, or the baker who refuses it for religious reasons? The age of consent in Nigeria is 11. This could challenge a wholesale commitment to cultural identity. When's it reasonable to curtail people's liberty? Motherhood and apple pie, you see here. But that's sometimes what our shared values are like. None of these questions are new. This slide will come as a relief to anyone wondering whether I can actually count, because the fifth principle that I said I would highlight. The Human Genome Project set aside money for a program to identify and address the legal and social implications raised by genomic research that would affect individuals, families, and society. It's possible to adopt a similar approach for the ethical, legal, and social implications of artificial intelligence. This could reassure Daniel Wagner that the things that should really matter need not actually be left on the side of the road. David Jenkins, a former Bishop of Durham, used to say that if God isn't on the throne of the universe, be assured that no person or no thing else can safely be elevated to take his place. We have a propensity to elevate things to the throne of the universe, and blind faith in artificial intelligence is just as dangerous as blind faith in anyone or anything else. Now, if you're a paramedic trying to stabilize a patient in the back of an ambulance, you might tell the driver to go as fast as he can. The human driver knows the nuances of the command: slow down at a red light with your lights flashing and sirens sounding, don't run over pedestrians, slow down for road humps. Tell an artificial intelligence driver to go as fast as it can, it will no doubt obey. Just an illustration of garbage in, garbage out. The information you put into an algorithm has all kinds of biases. How diverse are the people who develop the algorithms? Will their lack of diversity lead to unfair discrimination in decision-making? Well, of course it will. The good news is, though, that the outputs are measurable. If people with Wyburn-Mason syndrome are not part of a data set, this can be detected and corrections can be made. I picked this from a random list. I picked this at random from a list on the National Organization for Rare Disorders website. But if you didn't recognize it, you may make no provision for them in the data sets that you design. The House of Lords Select Committee on Artificial Intelligence says we're concerned that many of the data sets currently being used to train AI systems are poorly representative of the wider population, and AI systems which learn from this data may well make unfair decisions, reflecting the wider prejudice of societies past and present. More needs to be done to ensure that data is truly representative of diverse populations. Does anything strike you about this slide that Julian presented? I know that he didn't make a conscious decision to select two white Anglo-Saxons for this slide, and he's very generously allowed me to use this example so that I could give the impression that I don't actually have any biases myself. AI may give us a lot of information about things we dread. Remember the Rosling family's advice in Factfulness that's produced on their Gapminder Foundation website. Factfulness is recognizing when frightening things get our attention and remembering that these are not necessarily the most risky. Our natural fears of violence, captivity, and contamination make us systematically overestimate these risks. And a public health audience has a very appropriate thirst for information. Conceivably, it might blind you to considering its usefulness. I'll skip over this question, but it seems to me that it's not hard to answer because the Boland principle would still apply. If a skilled body of doctors have trusted AI-generated X-ray reports, does this actually stand up then to reasonable analysis? 200 years ago, many of us would have employed somebody to do our washing. When servants were hard to come by after the First World War, we would have had the washing collected and sent to the laundry. Now, I guess, we all have washing machines. Which most promotes human flourishing? Human contact with a washerwoman or a laundry van driver, or control and independence? We can ask this more acutely when AI is used to provide care. Aging may reduce my mobility. Is it more dehumanizing to be pushed in a wheelchair by someone I have to keep turning around to talk to, or to have the independence of telling my robotic friend where I want to do and concentrating on talking to those I've chosen? I've taken one of Susan Mitch's slides and added some questions. Which users? Whose voices are you going to ignore, and how will you filter the information? Is Y, when we're looking at the effect of X on Y, as important as the letters A to W and what they represent? In whose interests is this change? And what pattern have you detected? Hands up those who see the word good. And hands up those who see the word evil. You might be worrying about what that actually says about you. In summary, AI provides a new context for many old questions about human values. We've got a track record of muddling through as we negotiate different views of human flourishing. And we need to continue asking these questions. AI won't give the answers, but it will replicate the biases that are assumed by those who design the algorithms. If we critically evaluate these assumptions, and we have the answer to the question that is the title of this talk.
Thank you very much, Brian. It takes me back over 30 years to medical school when Brian used to ask the same questions of us, medical students. So thank you, Brian. So we had a couple of questions specifically for Susan and Julian. So I'm going to take those first before we then ask Brian to pose some ethical questions to them as well. So first question over there. Thank you. If you just wait for the microphone, because it's just coming to your right. and say who you are.
Yep. My name is Tahan. I'm a public consultant and in London Borough of Enfield. My question is two-part. And with regards to the way AI works, I know it's very complicated technology used. And I wonder whether we can build your AI in a way that it can quality assure itself and debug so that the data it used is already robust. Because these days there are many primary data, and we don't produce them anymore, and AI will use them straight away. So, but it needs to detect if there is any issues in it. And one example being, it's not an AI, but in computer programming now these days you use objects and modules rather than going and bits by bits as before. So as a result, for example, a road programmer puts something in like a BA program, and then is sending all the data out, and they don't detect, they just bought a module or an object. So similar things could happen. And if you have your non-robust primary data, I would like your AI to be able to detect as well. And I wonder whether you have thought about that. And second question is because of the boundary of what your system has learned, and there will always be a boundary, and how will it detect confounding factors? And because even ourselves, if we are a medical person, our limit is medicine, and there may be other things which may be confounding, which we don't know from like psychologists and things, they will know better. So,
thank you.
Like we work in multidisciplinary team, your AI can do in that way, and I would like to hear about that. Thank you.
I'm not sure I've completely got all your questions in there, but the approach can be used for primary data as well as for published evidence. One of the things I didn't mention is we're developing an ontology of study methods, whereby we will be able to record the types of bias that are in the study methods themselves. So that's one way of looking at bias. The other issue is you're asking, I think, if the system can monitor itself for bias. One of the kind of ways that we're thinking about this system is it's a kind of open system of interaction with human beings. So human beings will be continually able to feed back into the system if they think there's some bias, that's been missed. And just on the subject of bias, what we do is as open as possible. So we have many, many hundreds of stakeholders. Anybody can sign up to be a stakeholder, and we'll be involved in giving feedback about what we're doing. And we also do open science. So, for example, all the ontologies we're developing, they all have stages of open peer review where we send it to often hundreds or thousands of people to say, please, comment on this. So nothing will guarantee that things aren't biased. There will always, I think, be bias. There are two important things. One is to be aware of the problem, try and minimize it, and be transparent. I think that's what we can do to try and safeguard.
Thank you for that. And, on the question of boundaries, we talked about garbage in, garbage out. So it is very much how we respond to all those parameters. Julian, do you have a response for questions posed?
Yeah, these things are so complex. If you're trying to make predictions for health based on genomic data and clinical data, as well as society factors and psychological factors, that we are definitely going to need sense checkers. And that because, of course, it's not always what the patient says that's important, it's what they don't say. So there's all sorts of subtleties that need to be taken into consideration. It's not an excuse for us to switch our brain off when we are seeing patients or making public health decisions, and there is a risk with that. So we're very much at the beginning, I would say.
Thank you. We've got one question from the front here, and I'm just conscious of time, so I'm just going to make this the last question from the floor, and then Brian can pose a couple of ethical questions to our colleagues here. So, Nikki.
I was just going to ask Susan, how are you going to use your behavioural knowledge to persuade me that I can trust Google, Facebook, whatever, to give Julian my genetic data?
I can't speak for any other systems because not all systems are transparent and open. and give the workings as to how the answer was derived and what the degree of certainty for the answer is. You know, it's a big problem. And I think in life in general, we need more transparency and openness so that we can make our own judgments about what's going on.
Yeah, the social media is obviously a really complex area, and people are young people have a very different relationship with their feelings when it comes to typing and publishing, and that is going to have a huge impact on psychological medicine. I'm absolutely convinced by that and the way it's delivered, and I think it'll be welcomed by that generation to a large extent. But I do have some unease about it. How much it will factor into genomic data is more difficult to say, I think.
So let's just move into the final 2 or 3 minutes, Brian. If you could just maybe pose some questions specifically for Susan and Julian, I would be...
The specific question I'd ask, actually, which is a very open one, is what worries you most about the area that you are developing and the effect of artificial intelligence on it? Because I think often people who teach or say something about ethics actually, as my daughter would say, get up themselves and forget that the people who are actually doing this work are thinking about the ethical issues. And you don't need to bring an ethicist in who suddenly says, oh, had you thought about ethics? Of course you have. What worries you the most?
In whose interests is this going to be used? And I think that's true for all technology.
Yep.
So the more powerful the technology, the more good it can bring, but also the more danger it can bring. So, you know, we have the example of nuclear energy, which can save tens of thousands, possibly millions of lives. It can also blow the whole planet up. So I think being ethically aware and having good ethical frameworks around one is really important. I've made a note of the computer science, the artificial intelligence code that you suggested, but we sign up to an evidence synthesis code. The Centre for Behaviour Change has a code that everything must be about promoting human health and well-being. We don't accept money from the tobacco industry, the alcohol industry, the gambling industry, or the arms industry. So, you know, we collectively think about where are the areas in which this could be used for, evil's a strong word, but that may cause intended or unintended harmful consequences. And make it open, keep reflecting, and take advice, you know, because we're very collaborative. We've also just got funding for a PhD PhD student who's going to look at the whole issue of trust around all of this, which I think will be important. And as we go on, we're encouraging collaborative projects to work alongside us. So I think there's huge ethical questions to address.
Julian, in 50 seconds, I think.
You've got people, you need people who understand medicine, people who understand genomic science, you need economists, and you need computer scientists, and then you need policy makers, and there are very few that can do all of those effectively. And it's extremely difficult to get them to communicate, everyone's banging the drum to a different rhythm. Until you join up economic modelling with the healthcare system effectively in a real equation, it's not going to work.
So do we need critical trust between those two so that it's not ridiculous putting something on the throne of the universe, but on the other hand, enough to feel that we can work together?
And we should stop working in isolation.
Great, thank you. What a great way to end
messages.
on. Thank you. So, you know, I'm armed now with the Asiloma principles that Brian exposed us to. I now think of myself as a walking equation, and ownership is clearly important. But I think the next thing I'll do after this is go and get some dye for my hair in the hope that I might reverse some of the genetic mutations already there. And, you know, dealing with messy evidence is something we do every day. So can you join me in thanking our excellent speakers? And just finally to say that the final session for the conference is the keynote address by Professor Dame Teresa Marceau, Changing Minds About Changing Behaviour, and it will start here in 10 minutes' time. So please, if you're going to stay in the room, move along the rows, get close, because this place is going to be packed. So thank you very much.